going to be joined by Dr. Kim Blake, which is a professor of pediatrics at Dalhousie University in Nova Scotia, Canada, as well as Claudia Junghans. She is the first president for the German Charge Group and a mother of a 21-year-old son with Charge. Today, they're going to be sharing with you some very important information about adult medical issues in Charge. So we're really happy to have you, and you could begin your presentation.
Thank you. So I'm going to share my screen now. Okay, can you see it? Just give me a sign.
Yeah.
Okay, thank you very much. So, yeah, thank you for the opportunity to speak here. I'm responsible for all the datas. I will present the datas of our survey we did, and Kim will speak after me and present and talk about all the medical stuff. So I would like to give you a little bit of a background. Well, Kim and I, we attended the Australian conference 2 years ago as speakers, and there was a panel called Ask the Experts. And in that session, a young lady with Charge syndrome asked the following question: what medical problems can be expected in adults? So we thought it's a very, very good question. And everybody was very glad when Kim took over the microphone. But even she could only give a general answer because there are only case reports right now. Very old studies and nothing up to date, especially not for the adults. And in the end of 2024, Kim wrote me an email and she asked me if I'd like to present together with her at the American conference on the subject of medical issues in adults. And I replied to her directly and wrote that she had certainly used the wrong email address after I'm not a medical professional. But she denied and said, no, I mean you. So here I am together with her. And again, I'm not a medical professional. I'm the specialist of our son. He is now 21 years old. And I'm the head of the German group. So I have access to a lot of families and stories. I have no medical training, but what I can do is tell you what families here in Germany or Europe have experienced. So what did we do? Yeah, in order to have updated studies and data, we created a pilot study questionnaire. It was a very, very simple one. It was translated into English and German. And so today we will share the data from the pilot questionnaire that was completed by adults with Charge syndrome and or parents or caregivers. A reversed and more detailed study will be released hopefully within the next few months. We're just waiting for the ethic approval right now. And with this expanded study, we hope to reach many more Charge individuals in the future and families to get a wider range of information. So after this presentation here, you will have a better understanding of medical conditions like POTS, bone health, growth and sex hormones, mental health, sleep, GI issues, all presented and explained by Kim. Now, hold on. Oh, here we go. In our pilot questionnaire, we asked for the new medical issues, and that is important. We didn't want to know about the general issues. We wanted to know about the new medical issues, like vision, hearing, reflux, stomach, breathing, bones, heart, sleep, secretion, migraine, puberty, and so on. We also asked for physical and mental health in the end. Yeah, by the time we have finished this PowerPoint here for the American conference last year, we had 92 responses in total. We have divided the participants into following age groups, 20 to 30 years. That was the biggest group with 48 answers. We had 30 to 40 years with 33 answers, and older than 40 years, here we had 11 responses, and we very much hope that this new study will help us reach even more people in the group of over 40. Thereof were 42 males and 49 female, and one clicked the other button. We tried to spread our survey worldwide and got 48 answers from the US, 27 from Germany, 5 from Canada, and then we listed here others. That means we got answers from New Zealand, Italy, Norway, the Netherlands, Ireland, Australia, and UK. And who answered those questionnaire? We had 37 persons with charge answering the survey, and 55 parents or guardians. So now, what did the result look like? This is the most interesting question you're all waiting for. And here it goes. Yeah, surprisingly, osteoporosis was the top issue. Over a quarter reported signs of osteoporosis and have been diagnosed at the age of 30 and older. But I'm sure that osteoporosis is underreported. I had some charge adults in Germany who asked me to help in filling out the questionnaire, and they all ticked no for osteoporosis. And in one example, I know that this young man had arrested puberty and recently many severe fractures at a young age, so there must be osteoporosis, and I'm sure there are more, but nobody's paying attention to it. And I know of 2 more families from the German group that have now the result that they have osteoporosis. So there must be more than just the 22 you see here. Kim and I, we are planning a pamphlet on that to inform the parents to pay more attention to osteoporosis to increase the awareness. So second and third was swallowing, reflux, stomach, gut constipation. Well, we could see that the reflux is getting worse, stronger again, it's coming back. They could develop chronic gastritis. Same with bowel obstructions, it can get worse. What could be the reason for this? We assume that eating habits play a major role, especially in the adults, as do stress at work or at home, and medication that may no longer be taken. The next was vision. There are retinal detachments reported, glaucoma, worsening of vision. Yeah, that's about it. Then I would like to go over to the hearing part. It can dramatically worsen. So late CI implant or a bone construction hearing aid may be required. And in this context, we would like to highlight once again how important total communication is. That means to offer more than just spoken language, even if your child or the adult is able to speak. Sign language should always be a second or a supportive communication. Here too, I have observed in my German adult group that many adults are not aware that their hearing is getting worse. Most of them ticked in the questionnaire, no difference. So, but in everyday life, you could see the hearing is become worse. So my feeling is that hearing should actually be among the top three topics.
Yeah.
Next, I would like to point out spine with scoliosis and kyphosis. Almost everybody reported to have at least one of those two issues. They may not have worsened, but they are there. In most cases, the condition has worsened during growth, regardless of whether growth hormones were used or not. Some wear a brace or corset, and a few have required surgery. And again, a short story here. Many of them may not realize that their scoliosis is getting worse. I have a young lady here. She's now 27. They know that there's a scoliosis, but nobody looked after it. And now she moved to a new residential living group, and the team took her to see a doctor. And they told her that her scoliosis is already at 60 degrees. So not a very good one. And no, she's getting a corset, but we really have to look after her. And I know another young man, he's completely deafblind, and his scoliosis, for example, is even worse. And he's 21 too. He already has severe problems with breathing and digestion, and it's also assumed that he's in pain as he cannot express it in words. But we do have a pamphlet out on that topic, and Kim will talk about that scoliosis later. On the next slide, you see other issues. Issues were, of course, also mentioned in the questionnaire, but these were not ranked so high and only related to a few charts. The last one, migraine, here we had 19% saying that they don't know if their symptoms are migraine. So there might be more than just 4 people. And the next slide just summarizes the main issues I've already talked about. And on this slide, you see the first pamphlet Kim and I, we did together. We worked on that back in 2018. The pamphlet is on abdominal migraine, and it's translated into French, German, Spanish, Brazilian, Portuguese. There are many more pamphlets, as you will see in the next slides, and there are more to come. And usually Kim is responsible for the text, and I'm responsible for the layout, the pictures, and the translation. So, and all the pamphlets you see here in our presentation, they should be available on Kim's website. And she will show you the website at the end of the presentation. So, another pamphlet, it's on dental, because dental problems were also among the top issues in the survey. What we could see is in adults that teeth grinding is still a big problem, and cavities as well. Very important is a good dentist. We recommend to see a dentist 3 to 4 times a year. This might not be covered by your insurance company, really depending on the country you live in. I know we are a lot of people from all over the world right now here in this webinar, and it might cost you more money, but it's absolutely worth it to see a dentist frequently. Because even charge who are really good at brushing their teeth can have problems with cavities. This is often caused by their mouth that is too small, making it harder to brush their teeth, especially in the back, probably. And food pocketing is a problem too. Food that is left in the mouth for a long time, and also the reflux. This is already my last slide for my part. I would like to pay your attention to the part of endocrine. It shows us that 38% was on growth hormones and 59% got hormones because of missing puberty. But here too, we saw that more charge would have needed sex hormones, but did not receive them for various reasons. And at the end of our survey, we asked for other concerns, and the biggest problem was, or still is, the lack of coordination once you get to adult service. And this, believe us, is a worldwide problem, reported from almost everybody. And there were also balance issues mentioned, as well as cognitive changes. Yeah. And the last, there were the ranking of general and physical health and general mental health. And most of them found themselves in a good physical or mental health, which is actually good. But
Yes.
here, again, it depends very much on who filled out the questionnaire and what their point of view was. Now, I'm going to show you a very short video. This is a video from Germany showing the our charge adult group. And if you look very closely, you see Kim in that video too. And then it's just sound, but it says in the beginning, we are balanced even with balance issues. So it's a very, very short video. I hope it works. Yes. So thank you very much for your attention. I'm now head over to Kim.
Thank you. Can you hear me okay? Thumbs up? Yes? Great. Well, Claudia, that was a great overview. And Claudia is the driver of everything. She organizes me, she gets things going. Those pamphlets would never have happened. And they're still being produced. We're behind on a couple. So I've been researching in charge syndrome in many of the clinical aspects over 40 years now. And it's always so interesting. The families I've met, it has been a career making for me, and I am honored to be part of any presentation. But the groups, all of you that I meet, you are who I am, because I wouldn't have been able to do any of this without your help. And a lot of the ideas come from the families. They're instigated by Dr. Blake. What do you think? And I say, oh, we should look into that. Okay, so this is one of those: postural orthostatic tachycardia syndrome. So if you think of charge with all the cranial nerves being affected, and there are many of them, and we actually feel they're probably all affected, less so the eye ones, but the eyes have got their own problems. But essentially all those, you've got the lower cranial nerve, which is your vagal nerve, and this is where the POTS comes from. You will know about POTS because of long COVID. So many people are much more aware of postural orthostatic tachycardia syndrome. So it's an autonomic regulation disorder. So think of your system, think of any system being regulated by a sympathetic and a parasympathetic, a flight and a fright, and a fright, and a stationary, so the eat and digest and rest. So what we have with POTS is that system, like a lot of charge systems, aren't working. It is difficult to diagnose even in somebody that hasn't got charge. So I'm just going to go over a little bit about how to do it simply. I mean, it's not, you should do that like a tilt test, but really you can lie your individual down for 10 minutes, do a blood pressure, do a pulse rate. When they stand up, the blood pressure should not change very much, a couple of numbers, but the heart rate rises very rapidly, usually about 30 or 40 beats more than it was. And you do those readings over like 1 minute, 5 minutes, 10 minutes. And actually it's the 5 minute and 10-minute one that can actually go up even higher. So why is that happening? So what is POTS? So what is happening is, and it really makes complete sense for Charge syndrome. You've got vasodilatation. So look at our little picture in the middle. You've got the blood volume that's pooling, and actually often you get the lower limbs turning a little bit cloudy and blue, pooling and not getting up to the higher levels like it should do. So it's sort of like it all stagnates there and doesn't get up as quickly as it should. And that gives you the tachycardia, because your brain is saying, I want some blood, I want to feel the heart, you know, all the organ systems want that. So our next slide looks at the symptoms. So we look at symptoms of brain fog, that lightheadedness, a degree of fainting, heart tachycardia, palpitations, and fatigue. Those are the sort of the regular ones, but the abdominal ones can be quite significant. And I know that many of you that are on this webinar today, abdomen is one of your big things. So we'll keep coming back to that. And actually, it's one of the things I said to a very young family years and years ago when I first started. I said, many of the issues that you're dealing with now will settle, like the choanal atresia, all the things you're not the feeding, because that can come back, but essentially it's the gut stuff that stays. It's very interesting that the G in Charge probably should be gut, because the gut stuff seems to be so prevalent. And it's something that I've traveled along with my career with. I've traveled along with the gut. So you've got the abdominal symptoms of POTS as well. So we'll do next slide. So in summary, and again, I'm just summarizing all these issues because I could do a whole presentation, but it's difficult to diagnose. But in multisensory impairment, it's something you've got to go after and think about. Again, in that questionnaire, I think there's more of this than people realize, and especially more in adulthood. So it's likely in Charge syndrome because we know that there's pain and temperature regulation problems, and we haven't really looked into that enough, actually. So stress seems to trigger it, heat seems to trigger it. So looking at triggering, a bit like your migraine. So looking at what are your triggers? One of my patients in Prince Edward Island, she's triggered by very hot weather, and the mum knows that, and she will make sure that Charlie's having her electrolytes, and she's being aware of it. So being aware of it is one big thing. Electrolytes is with your fluid, exercise and conditioning, compression stockings, all of those help. And then I have a few of individuals that are taking fludrocortisone. I have a population of individuals with POTS who are in my regular pediatric practice, and so I follow them quite closely as well. It's a chronic condition that can be treated but needs to be looked for. So that's one of the things. Next slide, and we move on to, I think, our pamphlet on POTS, and you can see a tilt table test, which is a proper test where you actually have the table, but you can do it the lying and the standing. It can be done in an office. But a lot of the cardiologists like to do the tilt table. People ask me, who do I go to? Who do I go to as an adult with this? You could go and speak to cardiology. They're a bit on the fence about it, especially when you come as an individual with so many other issues going on. But as you guys do so well, persevere. And there is something called the vagal nerve stimulators, which people have been very interested in, and it can stimulate here on the ear, And the young lady on the left-hand side has one actually implanted. She had that for her epilepsy and the POTS, but it really helped her gut issues, which I want to put out there as maybe a future for Charge, is that are we going, like we see the cochlear implants, are we going to see a vagal nerve stimulator? It's it's a bit like the one that you use for the heart. It's a pacer. It's a bit like a pacer, and you can actually use a magnet to make it go up, and it has changed this young lady's life. Now, it was done because of her epilepsy. I'm hoping the future will be this for Charge. I think it will be a breakthrough. Next slide. So now I'm going to do growth hormone. I am not an endocrinologist. I have a wonderful expert in endocrinology that I reach out to, Jeremy Kirk, and he and myself are coming to Germany to present Claudia's amazing conference. It's the best one to go to, and very well organized. So what I'm saying about growth hormone, people get very confused. They say growth hormone, sex hormones. They are two separate hormones. You know, you've got your sex hormones, your testosterone, your estrogen. Claudia was talking about those because of the bone health and the and how it can affect bone density. Then you've got your growth hormone, which I just want to sort of mention here, because again, I like to mention new data, things that are coming out in the literature to inform you. So certain syndromes certainly reach a threshold for growth hormone, but we know that certain genetic syndromes, growth hormone's a bit iffy. You know, it's not quite there, but it's not quite low enough. Do you treat? Do you not treat? So the big thing is it important to treat in adulthood? You know, we hear about growth hormone being misused, but could it actually improve well-being? I think there is something in that. I think it's something to explore. You'd explore that with an endocrinologist, but there are positives. You've got a list of data that you can say it will be beneficial for things like your body strength, your mineral density to your bones, your general feelings of life, and your heart health. So I'm not saying everybody should be on growth hormone, but I think it's something now where we're seeing, and especially with that last reference, there's a very good reference, growth hormone now that's growth hormone deficiency, but they also talk about the low levels and that's not, there's not been enough researched on that. And again, a good resource to that is Dr. Jeremy Kirk. He'll probably say, Kim, I had so many emails about it. Okay, well done, Jeremy. I think he's on the webinar. Okay, next slide. So now we're doing the sex hormones. So this is the testosterone, the estrogen. One question came from a young adult who sent, we had 3 lovely questions last week through DBI, and said, should I still be on my pill? You know, when should I stop it? My endocrinologist was asking. Again, there's limited literature on Charge syndrome, but there's literature on other syndromes and other, you know, we have to take what we can get. So, and we have to try and help inform our doctors. That's what you guys do. You guys inform your own doctors. You are the ones in charge. So, and that's why you've joined this presentation, many of you. So I point to a couple of references which are from the Prader-Willi syndrome. These are quite good. They're at the bottom there. Always, we certainly are wanting to use testosterone and estrogen if they're deficient or not there, and that is in a large population of the adolescents with Charge. Going on with that is important. Why is it important? You've got essentially your bones, which are probably one of the most important things, your general sex drive, which I think is also very important, but also, you know, your general well-being and heart health. So yes, it's worth, and really, if you're replacing something, like you're replacing insulin or you're replacing something that needs to be replaced, you don't stop it. You keep going with it. So that's the answer to that young lady's question. But again, I think a lot of people may not be on enough. They need an endocrinologist. I think if you're going to get, You know, you probably don't, a lot of the young people with individuals with charge probably don't want to see any more doctors. They've seen enough doctors. Not a bad idea to have a check-in on a yearly basis. And, you know, sometimes you've got to teach the endocrinologist what's charge about. Again, Dr. Jeremy Kirk is great on that. Okay, next slide. You'll be inviting him to do a presentation soon. I can see that. So what Claudia mentioned, osteoporosis, this is a problem. And I do not think it's been treated adequately. We really push in early childhood, actually, for vitamin D, 1,000 units up to 2,000 when they're in adolescenthood and beyond, and calcium. You've got to watch your kidneys, but that's very rare. So vitamin D, calcium, good weight-bearing exercises. Now, this is all ages. You know, you don't, we as adults sit. We become very, like, we're not running around at school. We're not doing, so anything that's getting you on your feet and weight-bearing and some weights is very important. And it's good for, again, for your general well-being. Replacement of your testosterone and estrogen, that's important. Should you or should you not get a DEXA scan? So a DEXA scan is essentially looking at the density of the bone. It's okay to get, but you've got to adjust for your height. You've got to adjust for how tall you are. But I think it's not a bad thing to have and know what it is. I followed a young man in England, and you could see how his DEXA scan sort of deteriorated and how he needed treatment for essentially quite severe osteoporosis. This one at the bottom, bisphosphonates and, or I can never pronounce that, raloxifene. These are the ones, and there's many more now, that are specifically to help the bones. I think this is going to be a future again for charge. We don't see a lot of people on it, but there are more coming, and it's very interesting how this is opening up, and it's opening up in other worlds as well that are to do with bone. And I think that, you know, this is going to be a good one to explore and look into for bone health. This will certainly help that. And with the osteoporosis, as Claudia said, it can be that it's not found, and because it's just not found, you know, you feel a bit, you know, you don't automatically get fractures. It's not that bad that you're going to fracture by somebody shaking your hand. You're going to, but it is, you know, a compression fracture on top of everything else. We are seeing that as being a big problem, and that, as we saw from our questionnaire, is an issue. Okay, next slide. So again, we've not done the osteoporosis one yet. It's nearly finished, but we've got the scoliosis pamphlet out there, which I think again can be looked at as something from young to older, but particularly in adolescent when the growth spurt, but often growth spurts happen in adulthood. So scoliosis and looking at how to, and again, things like core exercises, working with physio. I'm very much in favor of working with your allied health professionals, physiotherapy. I've just started with osteopathy recently, and I find them really, really very, very good. I mean, it's time to go to a lot of these people, but I think they can give you videos and exercises, and if you do them, or you go in for a check, these are all, it sounds very sort of, well, it's just a little of this, a little of that. How many of us don't do our physio exercises? But I got to do mine after this. I forgot them this morning. Okay, next slide. So sleep issues. I know that Casey, who's a lead psychologist in Charge Syndrome, is working on this a lot. This is, and Tim Hartshorne has written some good papers and is certainly knowledgeable on this. So this is another huge area. And again, I'm not going to be able to address everybody's sleep issues here, but we as a community, as a world, as a population, I think if Artemis 2 could look down at us, you know, from up there and see what we were up to in bed, you know, all of us are, well, many of us on our phones, on our screens, or even during the day, you're on a screen, you're walking, you're on a screen, or you've got the little headphones in. I don't think any of us anyway, sleep is all about healthy life habits during the day and healthy life habits generally. So, you know, I tell all my pediatric population, you know, watch your screen time, exercise, don't eat too late. Just keep your bedrooms very cool. These are all simple things. You've been told this, everybody, but all these little things help. Okay, they are helpful for sleep. And our next slide. I have got a young lady who has very severe charge. She's come from unfortunately, she had an abusive growing up issue, well, a huge part of her life, and she is in foster care, lovely foster care, and she needs drugs to help her sleep. But that's the end of the spectrum. But she's doing a lot better. So these are the behavioral ideas. We've just seen some lovely video on Tai Chi. I think I might try and do that myself. I got to think about that now. Weighted blankets, more exercise than you think. Exercise isn't your 20 minutes a day anymore. I'm actually promoting outside school over an hour. So I start them with an hour. Now I don't start any 20 minutes anymore. I said split it into little lots. You've got to be doing more, okay? And that will help a lot of the behavioral stuff, and the next slide will be your drugs. So do not forget sleep apnea. This is a young man in Toronto, and he said this completely changed his life. He had it when he was younger, went back on again, had a sleep study done as an adult, and he was lovely. He spoke to me the other day with his dad, and he said, Dr. Blake, you've changed my life. And that's so lovely as a doctor to hear that. And he feels so much better during the day because he's sleeping at night. Bad sleep at night affects you during the day, affects everything, affects your whole system. So I used to promote melatonin. I'm moving more towards magnesium as being a better option. Together you can use them, but I think melatonin, I really think a combination of the two is good. And I think magnesium, I quite like the glycine, magnesium glycine. It's got some good gel capsules, and you've actually got a liquid that you could use as well. It stops that restless legs, that restlessness about 3 a.m. Good doses of vitamin D, zinc daily. If you wake up, I do this and it works brilliant. If you wake up at 2 or 4 a.m, another melatonin. And I think I use that with a lot of my general regular pediatric patients, especially the ones that have got, you know, severe neurodivergence. It works. Clonidine or Intuniv, similar drugs, can work very nicely. I've used those. Both it's a relaxer. It calms that nervous system down. It does well for a bit of ADHD in the morning. Clonidine you have to really use a couple of times a day, but it does make you sleepy. So I try it at night, and then I might use it at 3 when they come home from school or something. Those are the kids. But at nighttime, I think it can be quite good just to calm things down. Trazodone, I don't use very much, but my little kiddo who's in foster care is on it and doing very well on it. And she's on a combination of Trazodone and Intuniv. Okay, next slide. So mental health. Tim Hartshorne would like to get up now and speak on this himself, and I'm sure he has done. I think he's actually, I think you know him very well for DBI actually, and me less. So I'm going to push the Dr. Blake mental health. You have a diverse population with Charge syndrome. They are neurodivergent in many ways, in many different ways they are. Yes, I agree with my colleague Tim, it's not all autism. There is a very much I've moved away from that. He's going to be very pleased with me, but I'm moving towards anxiety. So anxiety is huge. This is why not? Why wouldn't it be? We're all anxious at times. I'm anxious now. We're all anxious. But if you've got if you're dealing with your body just not, being where it should be, you've got used to it, your balance. But anxiety is a big one. And I started to treat anxiety more aggressively and earlier. I do think that the psychology aspects of anxiety, like CBT, like all the behavioral anxiety treatments, sometimes you need the drug as well. Do you need to be on it all the time? It's prevalent in families. I look at family history, so is ADHD. So I look to see what worked in the family. But I do like now treating medically, like looking at medication for anxiety. So I've started, I've got a couple of young people on fluoxetine recently, and it's doing very well. So it's usually very well tolerated. Vyvanse is a drug for ADHD, and ADHD can happen with charge. Again, they're all overlapped. They're overlapped, and again, it's a very strong family history usually of those things as well. But Vyvanse has a good anxiety component to it as well. And then we're back to the old vagal nerve stimulator, which I know Claudia's been experimenting with. I've been experimenting with. Her son used it. We actually brought it to the last conference, and we had some individuals with charge try it out. They liked it. It was the one around the neck. I actually I don't think I've got it out, but it's the Pulsetto. And I think I would have loved to have actually done a study on this. I looked into it. I think somebody should do it. It's waiting to be done. I think the companies would actually sponsor, but I'm siding with Claudia. We're continuing with the adult stuff, which I find is more fun. I like working with Claudia. Okay, next slide. So this is what you've been waiting for. I know, the GI conditions in charge syndrome. So I had a phone call yesterday from a young doctor. He sounded very young. Excuse me, George, I think you were from Vancouver. Anyway, he was desperate. He said, I'm a gastroenterologist. I said, I'm not. He said, yes, I know. I said, I am a charge expert. He's a gastroenterologist. He said, I do not know what to do with this young adult. It's chronic vomiting, and it's very interesting. 28, and the G-tube came out in adolescenthood or around that time, in late. Feeding, eating well, enjoying life, no problems. And then the last couple of years have been hell. Huge amounts of vomiting, which sounded at the beginning, when the parents first reached out to me, sounded more like cyclical vomiting, like it was on some sort of cycle. And the history I took a good history back then, and I need to speak to the parents again, was quite a lot of OCD coming in, quite a lot of obsessive compulsive behavior, quite a lot of anxiety behavior. And I said, why don't you try and treat that? And actually I did say that to the GI specialist. I said, I went back through my notes, and I'm not sure that was ever addressed. Now she's losing huge amounts of weight. She came in with I think very distended stomach, not twisted bowel, but lots of loops of small bowel. So this is what I'm hearing. These are the very difficult these are the top end of the GI spectrum in adulthood. These are the volvulus twists. These are the vomiting. And it's all, I spoke to George, it's all gut motility. It's the gut not working. The gut is not doing it's what it should be doing. And think of, the gut is a motor organ, it's got to push things through. So when I first looked at adult issues with charge syndrome, this was back in, the paper was published in 2016. So as Claudia said, we've got very little up-to-date literature on some of this stuff. So we decided that, we had this pocketing and overstuffing we've talked about with the dental issues, abdominal migraine, of course, cyclical. Late onset volvulus was also becoming something I was seeing. I'll talk a bit more, and something called dumping syndrome. So they're all a little rare in themselves. They all sort of tie in together, I think, with the one caveat that it's probably the vagus nerve that this is stemming from, with on top, because the vagus nerve feeds back, you know, to brain, gut, brain, and it does a lot of things. It does a lot of regulations, a lot more information. So if you want to follow something, follow vagus nerve, follow the pot stuff and vagus nerve. Okay, next slide. So I know a lot of people want ideas for treatment of the gut. So the gut is not working. We know that the stomach is actually often, if you want a nice background paper, there's the zebrafish paper that's on my website, which people like to use. It's not readable very well. I didn't write it. I'm not somebody else wrote the main bits of it, but it's a nice summary, and there's some nice posters about it as well. So essentially, vagal nerve is your 10th cranial nerve. It's one of the lower cranial nerves in the of all of them. It's the longest one. It affects a lot of things. One of the biggest thing is the gut. The gut is the biggest organ in the body, and it gets forgotten. Very, very few of individuals I know with Charge syndrome have a gut specialist, have a GI specialist. More should have this. And it usually stems from the fact there's so much going on when they're younger. They have usually a specialist for all the other specialist things, the heart and the breathing and the ENT, but the gut, you know, people don't see it as a charge as a gut problem, but really I think that needs to change. So the ones that do see a gut specialist, the ones that end up in hospital with twisted bowel and volvulus and all this vomiting, and that's not uncommon. It's not common. All right, I want to reassure you that, but it is something that can progress. So back to treatments. My young GI person yesterday was starting prucalopride, and I said I'd love to know how that works, because it's the one drug that I think has come out recently that could be very beneficial. We used to use something called cisapride, which is at the bottom there. It was wonderful. It was a motility. It moved things through. We used to have babies on it. It made such a difference. Then it was taken off the market. They brought this one in. I don't think it's as good as cisapride, but I think it probably can work well maybe with others. So we were talking about this and maybe having drugs that will help the transit. So when you've got, I think I've got the constipation coming up in a minute, but you've got things like domperidone, which is often given for the really the babies that are having problems with vomiting. We've got to go back to basics. We've got to think about where's this coming from, and then could there be some anxiety component? Is it something we can increase the motility, increase the gut movement? So and also probably you need your acid suppressants. I think the next one I think is that constipation. After that, Claudia, let me just go next slide. Yeah. So so that's our constipation pamphlet, and we do a little bit on the vagal nerve there. But can you just do the next slide? I want to see where we are next after that. No, go back 2 slides actually. If you can go back the next one. Yeah. So I know that this is probably one of the biggest areas, and it may be the questions that we're going to get, and I'd be very happy to, you know, help increase your knowledge on this, but it's not a quick fix. One of the things is to treat constipation early, treat gut early, get the gut moving, and don't sort of what would I say? Don't forget the gut, even if the gut's working well. Be kind to your gut. So guts are always they like good diet. They like to move, and it's a bit like moving as you get to be an adult. Things our guts sort of get a bit floppy, they get a bit relaxed. You know, you have a situation where you're not eating as well, and it's, you know, common in adults, and you're not moving as much, you're not doing your exercises that you should do. I'm a real pusher of exercise. So we'll just go to the constipation pamphlet. This was one of the earlier ones that we did. There have been a couple of papers published. So last year we published the POTS one and 2 papers, one on constipation and one on the microbiome. So those are available through PubMed, very available. There are good PowerPoints and not videos yet, but we want to put some more on my website. But essentially, you've got to treat top end and bottom end, and you've got to be hugely respectful. And I think one of the things I've seen is when the G tubes have been in for a long time, which they often are, and they're taken out and things are fine, don't be complacent about that. I think it's something, especially if you had some issues with gut. The other thing that can happen, which is the volvulus, is it can twist, because the gut itself is usually sort of stuck down on with the omentum, and so it stops it from twisting. We're now knowing we've got about 8 individuals who have had volvulus in adulthood. We are going to put that together as a little paper, my students doing that. But it's when it's a problem, it's one of the biggest problems. So it certainly is something. And the fact that I get the GI specialists from Boston, Toronto, from other places calling me to ask for help, you know, shows you that, you know, they're reaching out for help. I am going to go back to vagal nerve implants. I think this is going to be the future. I hope I'm around to see it. I hope I'm around to see more people. That, you know, it's such a small operation. It sounds horrible. It sounds, oh my God, you know, neurosurgery. Oh, neurosurgery is not rocket science. No, yeah, you cut it open, you put one in, and it does. It's actually, most of us could be a neurosurgeon. Actually, they just think they're special. Okay, but neurosurgery, we want the neurosurgeons on board. They are getting on board with sort of stimulation of vagal nerve with things like depression, with some other bowel issues, hypermobility, where your joints are very mobile, Ehlers-Danlos. So there is much more literature coming out. This is going to be the future. So I love presenting things that may be, you know, a bit pie in the sky, but they're not completely pie in the sky. And there are things out there that you can use. So let's I'm afraid they're a little bit expensive, but not that expensive. And you know what, everybody can use a bit of stimulation of their vagal nerve. I think it can help. It's not contraindicated for anybody. Great for anxiety. Okay, I think we've got 2 more slides, quick 2 more slides. So I've got a website. I just put down the boxes, which is how to get into. The latest checklist is actually right at the bottom of the website if you want to click into it. Claudia and I are hoping that we can actually make one of these for adults with charge in a slightly different way, but to have it specifically for their care. So that's our want after this piece of research is done. We will be so grateful if a number of you can complete the form online. It's going to be a up-to-date questionnaire. If you've done it before, do it again, because it's going to be new, and we've taken away lots of questions we didn't. We've got a great research team working with us. Both students are wonderful, and we hope to have some data to at least address at the German conference. But you know, we will be collecting data over the next 6 months or so. If you want any information, contact me or Claudia. We can get that to you. I can get my student to give you the site. It's not up yet. It will be up once we get a tick from ethics. This is our POTS video. This is our young lady, I think that's got the POTS presentation, who had the vagal implant. And as I say, she's her family are so happy. And Roya on the left hand side is my doctor neurologist I work with. We've got the pamphlets up there. There's a lot of information there for you, and it's quite nice. It's in boxes, so it's nice. I've had people say, as websites go, it's really simple, which is great. And certainly look for those new papers. I'm not sure they're all there. And last slide, and I think we've kept it under an hour, Claudia. So knowledge translation. One more thank you slide after this. There's a lovely charge syndrome textbook, but like all textbooks, they're always dated, so they're not. But it's got a lot of good information. A lovely adolescent chapter. Tim, Meg, and myself edited that. You've got lots of information. There's an amazing MOOC, massive online course. If you haven't seen this, Australia put this together. It is fabulous. They did an amazing job with that. You've got my website up there. The foundations want new families to come. They try and pay for you. There's lots of information from foundations, as with DBI. And my last slide, I wasn't able to get the new picture, but we have Claudia's delightful family on the left-hand side and my delightful family on the right-hand side. And I have a new little grandchild who just got born 3 weeks ago. And I have 2 more on the way. So the 2 on the left are pregnant, the 2 behind on the couch are having their second one. And we've got Shoshi and Elliot. They're sitting on Auntie's lap next to, oh no, the mummies are mixed up. Anyway, they're all there. So, except for the baby. And he's called Pim. Yes, Pim. Don't ask me. Okay, it's Willem. Pim. Thank you very much. And we're hoping that you're going to ask some questions to us.
Yes, thank you so very much. I just wanted to also share that we have been sharing the links to your pamphlets, Dr. Kim, as you were presenting. So they were in the chat, and we're also going to share together with the presentation and the recordings once they're available to everybody that registered. So we'll have Heather now look at all the questions that we have and see how we could get through them.
Or can I mention one thing? There's another paper that's just come out. It was actually published this week, which is amazing, in the pediatric Australian journal, the Journal of Pediatrics of Australia. Anyway, it was actually on the new charge checklist. So that charge checklist is more up to date. It's new. It's got more information on it. And it's been published with a review of different, I mean, it's not just for adults, it's for all ages, but it's literally just come out. And I can send that to you, and you can advertise that one as well.
Yes, thank you so much.
Great, thank you. Yeah, so we do have some questions. I will read them out. There's sort of a context around them, so I'll read the full question out. The first one we have is from Anna. She says, my daughter has had facial palsy practically since birth. She's 25 years old, and it seems the palsy has started to bother her. She's non-verbal, so I don't know what she feels. She sees an ophthalmologist regularly. She uses drops and ointment to prevent eye dryness. She pulls up her left cheek constantly during the day. My question is, can facial palsy cause discomfort with time? And what can we do to remedy? She will not sit still for warm compresses a few times a day.
Claudia, have you had any of your group treated for their facial palsy?
We have 2 that had a surgery. I know that. Adults.
Did it work?
In one case it worked, in the other one it was kind of okay.
And I think I've had the same experience. So I've had a young lady that I followed since she was very young, and she was very troubled by its look more than anything else. So by how it made her look. So she had some surgery, and there are various surgeries that can be done. but they did it in a 2-stage. They wanted to do something small, and then if they needed to do, and she had the 2 stages. She's very pleased with it. She feels it's given her a better look and a feel. And I think the plastic surgeon tried to. So when you've got facial palsy, the side that's not palsying is up here, it's sort of moving up, and it can cause a lot of strain on the muscles here and the muscles here. So it's you know, if you're like that and you're trying really to make your face symmetrical, and I would say I think it can be uncomfortable and it can not look right. So a couple of the other little ones that I had when they were, so I've had some individuals with charge that had very few features, and this young lady, Maya, had Botox injections in the good side. So it relaxed all of this. So this wasn't pulling, and she became more symmetrical with that. But actually over time, the face does seem to find its own symmetry. It's like the nerves readapt. But if they're not, and it's this young lady is got discomfort, so I'd recommend seeing a plastic surgeon specialist that specializes in facial surgery, perhaps congenital syndrome facial surgery, and some of them do younger ones and older ones, and look into that, maybe with Botox as well. They do the Botox as well usually, and that might be helpful.
Thank you, Kim. Okay, so I'll just keep going through the questions. We're getting a few more coming in. So we have a question from Liv, I believe. So regarding swallowing, and does deterioration sometimes lead to impossibility of eating, even mixed orally and G-tube feeding?
Can you repeat that? I missed the beginning.
Yeah, so regarding swallowing, so does deterioration sometimes lead to the impossibility of eating, even mixed orally and G-tube feeding?
Claudia, are you understanding?
You mean that it goes back from oral eating into G-tube eating? Is that the question?
It looks like it's more
I'm
like
not entirely sure.
they're asking about deterioration.
Yeah,
Deterioration in swallowing. So is there deterioration in
yeah,
swallowing in adulthood? I say yes to that. There can be. So I think the gut stuff can deteriorate, and I think this is what we've been worried about and seeing, and this is where the vomiting seems to be coming from, and so you've got a number of organ systems. Well, not organ. You've got the gut. Gut is mouth to anus. I always say it's top to bottom. There's a lot of gut going on there. So with bad reflux, so reflux is what Claudia mentioned right at the beginning, that can get worse. And why it gets worse, it can get worse in regular individuals. You know, many of us have all got reflux because we're stressed and we don't eat well. So if you're eating too fast, you're eating fast food, you're not really looking after, you know, you're eating, and you're also have had reflux as an infant. I think if you've had gut stuff as a child, as an infant, that gut stuff can come back, and it can come back viciously. So I think it's something that can deteriorate. Yes. What to do about it, I think that's where you probably do need a gut specialist. And I would point people to motility gut. That's becoming very common now. It wasn't about 10 years ago, but there is people now that are trained in gut motility. It's very interesting. Many hospitals don't have a lot of the testing that can be done for gut motility. My guy yesterday didn't have it there, but he knows that's the problem. So I think the short answer to yes, it can come back. You've got to think about reflux, treat that aggressively. And then you need to think about probably getting a scope and having a look at the gut. But that sometimes comes back normal, but it's a mechanical thing. And then thinking about how to promote, so small amounts, chewing a lot, swallowing, pacing with some sort. We saw a picture of Sarah, I forgot to mention that she had her iPad there. She was using that for pacing her swallowing and eating so that she could know now's a good time to have another bite. And many of us could do with that. You know, how many of us rush a meal or rush lunch and then, oh, I've got some reflux, I need a Tums now. So I think looking at top to bottom is very, very, very important. And yes, I think the reflux and feeding issues can come back, unfortunately.
Yeah. What we see is the muscle tone too. So
Yes.
swallowing can become also difficult due to the muscle tone. They choke, and as Kim already said, watch the eating very carefully. What you eat, the pace.
Yeah.
Drinking and eating the same time could be a problem too. So yeah, this is coming back.
Yeah. Speech language pathology, OT, they do a lot of that as well. So looking for therapy for that side of things, and again, watching your physical therapy and stuff like that. I'm hoping that's answered the question. If not, the mum can rewrite.
Thank you. Okay, I'll go on to the next question from Ashley. And she says, in Canada, physicians don't tend to suggest higher doses of vitamin D. Is this the case with physicians supporting with charge? And should parents and guardians be suggesting these dosages?
Yeah, I think I mean it depends on what country you're in. I know in North America we do 1,000, 2,000 units. And I think suggesting, I mean, I think again it's because of bone health, it's because of we do know that the individuals with charge are at risk, significant risk from osteoporosis and scoliosis and bone problems. So I think that it needs to be suggested. Even now, our regular population, we've gone from 400 international units to 1,000. We often say now to the kids, especially in places where they're not getting a lot of vitamin D in fatty, in fish, in sunlight, we're putting sunscreen on, but it's more than that. You need good doses. So I think any 1,000, 2,000 when they're certainly bones are developing, adolescence, and if you've got bone problems if you've got bone problems as well, I would say I'd probably have them all on 2,000 actually.
Okay, thank you. Next question is from Charlene. So my daughter is 37. She's had an MRI of the spine in 2022. This showed bulging discs at cervical spine. We were not told to do anything about it. Now she was diagnosed with myelomalacia. I don't know if I've pronounced that right, I apologize. And disc compression. She's in a wheelchair now. We have an appointment with a spinal specialist. Very upset that this was overlooked by doctors, and she was losing her balance, and no one said it was from her spine, or that we should take some action from bulging discs. Do you know of any other individuals with this situation?
No,
You've seen people with disc problems though, haven't you, Claudia, or not?
No.
So if it's just discs, I'm wondering what the spine itself, like the vertebrae, whether they were collapsed. So it's probably the vertebrae were collapsing. So it does sound like that there was a problem with the bone health of the vertebrae. Actually, that's such a sad story. That's I mean, that's not an unusual. I mean, this is unusual in itself for this condition, but being told don't worry about it, or being told, well, why do charge individuals need high doses of vitamin D? There's a lot of, I mean, there are some papers, but they're small, and there is recommendations for us as specialists, and those aren't small. Those are lots of recommendations, but that's I'm sure that's probably from from the vertebrae. Again, I think getting your specialist. I'm not sure what else for suggestions there. That would have to be the spine specialist and the people that specialize. I would very much make sure she's seeing somebody with endocrinology with bone expertise, that has bone expertise. Going back to my slides, I think the bisophosphates, so those drugs probably would be very useful. I think looking at the regular bones and looking at DEXA scan. I think looking at a combination of endocrine, orthopedics, you know, the probably neurosurgery as well. You need a combination of doctors for all of that. That's very sad.
Okay, thank you. So there's a few questions on the vagus nerve stimulator. So what brands are being recommended and where they can be purchased?
Well, we both have the Pulsetto. Kim and I, we use the Pulsetto. We just brought it in the internet. It's free. Yeah. It's not that cheap, but yeah, it's useful. We used it for stress. It didn't work for our son for the GI problems, but he doesn't have that much problems actually. But it could help with stress when you use it in the morning or after work. And we used it with secretion to increase the secretion in certain times. So we use the Pulsetto. It's very easy to use. You have an app and the device you put on the neck, that's it.
And it's the only thing about the neck is it sometimes doesn't fit as well on some people's necks. But what you can do with the back of it, you can put a little cushion or something like that, or a little something, and it's finding the right, because it's got to connect to the vagus. So if your vagus nerve stimulates, you can stimulate from the tragus, from the ear, which I don't think people like so much because of the I've not used that, and I've not seen a lot of people use that, but there are a lot of different ones. I would look, research. Things are coming out all the time, and look at the comments. Also, I do know many more individuals with charge are using these. So you could put an ask on the Facebook site or on the international site and ask, you know, who's used them, what do you suggest? Neck, how your neck is important, but I think it's like everything, and everything like that. It's like your physio exercises. You got to use it regularly, and not many of us aren't good at doing that, because then you feel better, or you're not sure it's working, and then you stop using it. That's what happened with me. I stopped using it, but you know, we tried it out on quite a few of the people at the conference who were just presenting, like the presenters. They liked it, so. That's the Pulsetto. I won't advertise that as the only one. There's many things out there, so please go and do your research online. I think is the best thing.
Yeah, and you have to play around with the settings, because in our son we had to set up. You turn up the setting so he can feel it. I didn't like his setting, but he liked it, and he was
needed it higher, didn't he? He wanted it much higher. I've noticed that. Well, think of it: if your vagal nerve isn't working as well, you really want to stimulate it, you know, because it's for the vagal nerve. So I did notice that they wanted like 7, 8, whereas we are, or 8, 9, whereas we are happy on it on 4 or 5.
That's correct. Yeah. And he's able to hold it like this, even if his neck is too short, but it still works.
Okay, great. So the next question is from Mairead, and she says, SSRI medications can sometimes impact testosterone production and result in sexual dysfunction at various levels. Any thoughts on this?
Well, that's a very good question. I hadn't thought about that. That's a very good question. I might suggest asking Dr. Jeremy Cook that question. What I do find with SSRIs is I use very low doses. I don't have to go up very high. And actually, if anything, we've got one individual I'm working with who is working with a psychiatrist and myself, and she got it compounded and did a gel, because he doesn't like swallowing anything. He's very bright, very sort of with it, doesn't want drugs, but he likes the gel. He puts it on himself and he rubs it in, and so he's on a low dose SSRI, and it's working well for him. My other little girl that I was talking about, that was in foster care, she didn't do very well on the SSRIs, but I think her issues are coming a lot from abuse as well. But I find that when it works, it's brilliant. My young lady who's now in her 20s in PEI with the POTS, it's working for her. It was night and day. The mum said to me, I remember when she went on it at 16 or 17, she said, oh my God, if I knew this, I would have had her on it when she was 6. She said it has completely, and it's not that it's, you know, she was able to do the behavior therapy. She was able to, and even Charlie says to me, I like my meds, you know, I want to keep on my meds. So that's a good, you know, sort of thumbs up to it. Yeah, I think with the testosterone stuff, like a lot of drugs, it's balancing. I often go to my pharmacist and ask, you know, you can do levels of, again, endocrinology would be your go-to person for that. Because think about it, these are common things: anxiety and using testosterone for whatever, sexual dysfunction, or so it's not an uncommon thing for endocrine. So endocrinology would be the go-to person.
Okay, great. So there are some questions, or some people have asked multiple questions. I will come back to you, but I'll try and answer questions by other people, if that's okay. First, so the next question is from Tracy. She has said her son, I believe, has started to have deterioration in his hearing due to repetitive ear infections. We've begun investigating the BAHA. Does anyone have any experience with this, with their adults with charge? I think her son is 27 years old.
I think you do, Claudia, don't you?
Yeah, we had the same. Yeah. So we had to go from the regular hearing aids into a bone construction hearing aid because of worsening of the hearing. Yeah. Well, our son is not that old, but it already happened when he was 19, 20. Yeah, that could happen. They couldn't give us a reason for that, but we see it with the others too. So that you might need to go to a different hearing aid. That could happen, yeah.
And I think keeping a check on the hearing. I think the hearing still, we suggested vision and hearing regularly, you know, at least once a year for those. I think that's very, very important. And I think with ear infections, they do seem to come back as well. Again, it's hard to know why. I think just everything seems to deteriorate a little bit more, a little bit quicker. So I think, you know, I always say to my young patients, if you've had lots of ear infection, get a hearing check. You know, ear infections equals hearing check, and to keep abreast of that. And it wouldn't surprise me that you need to change. I'm not a hearing specialist, but modalities.
And you should go for it. I just wrote the question again. The man with charge is against the a new hearing device or experience. You should go for it, of course, because it could get worse, even more worse, and that makes something with him and the communication and social living. You should go for it.
Okay. So the next question is from Carol. She is a parent of a young man who's 26. He has developed issues with his gut in the last 2 to 3 years, and these are now at a chronic stage. He is unable to describe what it is or how it feels, and he is on a bowel management plan, which is a combination of various medications. It's not working. What would be good to see from the research is about managing these issues. The pamphlets are very child focused and not always applicable in work with adults. it's hard to engage with consultants in the UK for patients who won't be examined and who can't have an enema for clinical investigation. He doesn't understand about exercises like Tai Chi or yoga, and more information about what constitutes a good diet would be helpful.
Another pamphlet, Kim. Good
Another
diet
pamphlet.
pamphlet.
Good question. I mean, I think diet is we are what we eat, and I think we've realized that what is in our food is so many additives and so much things. I know families that have this is general, and this is, you know, again, I'm a pediatrician, but stopped dairy. These are adults that I know that have stopped gluten and dairy, and that's worked, you know, quite well. For the gut doesn't like a lot of things that are complex, and to go back to, but this young man might like all, you know, that might be his joy of his life, loving those things. And I mean, prucalopride is a good drug for the bottom end. It's actually better for the bottom end than the top end. It's good for constipation. It's good for motility. So if it's a motility problem, I would do a couple of things. I would keep the stool soft with something like a PEG, Miralax, it's called polyethylene glycol, so that draws water in. That's, a lot of people know that, you know, it's a scoop and you add it to a liquid water or something like that. It's better put in the fridge overnight, and then you can drink it, and then you use that regularly. But you also use a stimulant, which usually I start with Senecot. I'm just watching my cat who's being looked at by another cat. You have Senecot pushes things through. Prucalopride is supposed to be the new drug that does a little bit more than just Senecot. A lot of people in the UK, well, a lot of people have moved away from Senecot. We used it back when I was a young doctor. We used it all the time. It's brilliant, and it doesn't have. People say, "Oh, you get hooked on it." Well, you're not hooked on it. You're on a medication because you need the medication. So, you know, don't worry about those things. Yeah, I think again, I'm not against people seeing alternative complementary therapies. David Brown really loves the complementary therapies. He's into massage for the abdomen, and he will sort of demonstrate that can be very helpful. And your person that wrote the question is quite right. This is why we're doing this, and this is why we've had a lot of people join us today, is because there isn't much information out there, and we've touched on it. And, you know, I haven't been able to give full presentations on each thing, but the gut stuff, there's quite a lot on my website on the gut stuff. And there is thoughts that, not that I've got shares in vagal nerve stimulators, but they can help guts in some ways. But I think you need the other stuff as well. You need to get that gut. And of course, you've got a microbiome that's going on there that feeds back to the sort of the systems in the brain, and it feeds back. It's part of the anxiety system. You've got so much happening in the gut. You've got the immunology component of the gut. Gut is what it's all about. So trying to keep that as healthy as possible is probably the way to go. Yeah, it's tricky because you're fighting the motility, and then you've got the stagnant gut, then you've got constipation, then you've got bloating, and the bloating seems to be the gases build up. So if your microbiome's not behaving, which happens because you've got poor motility, it's stagnant. It's like having a stagnant pool of water. It's got all that fermentation happening. It's not moving. And when we looked at the zebrafish, we saw the regular zebrafish that were fed, it went through the gut quickly. The charged zebrafish, it moved, then it didn't move, and then it didn't move, and I mean, that's the paper that showed us that this is what was happening. How to get a better microbiome. So that might be the literature you want to look up as well. You know, how can we promote a better microbiome?
Awesome. Thank you so much. We have one more question. The mom says, I have a daughter who's 20 years old. She never had any intestinal problems. until recently that she went through an endoscopy under anesthesia. After that, she's been struggling going through the bathroom. So would that have caused, would the anesthesia of the procedure would have caused this?
I don't think so. I don't know why she had an endoscopy. That would be interesting to know. So endoscopy is usually from the top end. Colonoscopy is the bottom end, but I don't think they're connected. Yes, that sounds a bit odd, and I don't know why. Why would she have had that test? It must have been something was worrying them, whether it was reflux or something like that. But I'll come back to the stuff that's common, which is reflux and it's constipation, and trying to treat both of those.
Okay, thank you. Well, Heather, do we have time for one more, or I think we need to start wrapping up?
Do you want me to ask one more? Or do you want to wrap up?
We have 2 minutes left, so let's just it will be safer to wrap up for now.
Yeah, I believe so. Yeah.
Yeah.
Let's-
So thank you so very much, Dr. Kim, Claudia. It was an amazing time. Obviously, we see that this is a very important topic for our community. We have tons of questions that we won't be able to answer. And so maybe this is a good opportunity for us to have a second part of this in the near future. So like we shared at the beginning, we're going to be sharing copies of the information that was shared today, copies of the recordings, and a lot more information next week for you all who registered. Thank you so much for joining us, and we hope you join us for our next webinar. Have a wonderful day. Thank you so much.
Thank you.
Thank you.